So this is Mike Taylor. I'm an intensivist in Cleveland, Ohio, and chief medical officer of a small hospital. And today we're going to talk about some basic topics in surgical critical care. The broad topics we'll cover will include shock, going over the various types of shock, but really focusing on hypovolemic and distributive. We'll explore some concepts around fluid resuscitation and those endpoints of resuscitation, briefly discuss use of pressors and inotropes, and then transition into a broader discussion of sepsis care. And then we'll change gears and finish up with some basics of ventilator management. So to begin with, shock was initially a pretty nonspecific term, and the first time it was used to describe a medical condition was in 1743, but it was really more due to the results of a violent blow and not a physiologic state. And this was in a discussion about injuries due to gunshot wounds. But about 70 years later, in another book on injuries due to gunshot wounds, the term shock was used to describe a physiologically unstable state. And then later in the 1870s, the classic definition of shock, penned by Samuel Gross, we called it the rude unhinging of the machinery of life. And I think this very poetic description is really quite relevant even now. But this is when physicians began to really understand shock as a circulatory process in particular. And we fast forward to the 1930s and the seminal work by Alfred Blalock to really describe the role of hypovolemia and blood volume loss leading to this physiologic condition of shock. And then he further expanded upon it to describe some other shock classifications, including neurogenic and vasogenic. Now, there was this work being done through the 1930s and into the 1940s and World War II, paralleled a lot of discussions about blood transfusion. In the setting of hemorrhagic shock, it was understood that aggressive blood transfusion was a necessary element to resuscitating the patient. But initially, this was felt to be unmanageable due to the difficulty in providing matched blood in the combat situation. But by the end of World War II, it became obvious that this was essential to the management of major shock, and great strides were made in blood banking and transfusion medicine to address this. After World War II in the 1950s and 1960s, we honed our ideas about how to establish an effective fluid resuscitation. And this was highlighted in 1964 with Tom Shire's demonstration of how useful isotonic crystalloid could be used to begin a shock resuscitation, to be followed by blood transfusion. And ultimately, this became the ATLS standard. Of note, Tom Shire's was really one of the forefathers of modern trauma care in his work at UT Southwest in Dallas. And in fact, Dr. Shire's is the physician who initially evaluated and declared the death of John F. Kennedy, and then later on went to operate on the man who shot Kennedy. Now, as ATLS progressed and we understood fluid resuscitation better and better, the general approach at that point was kind of all types of shock would get treated with massive amounts of fluid. And we were able to get patients through that initial shock resuscitation, but then they would go on to develop renal failure, and they were dying of renal failure. And a lot of the initial treatment to prevent and treat that renal failure was to give more fluids. So we got patients through shock, we got them through their renal failure, and then in the 1970s, it was understood that excess fluid was leading to ARDS. And so it's taken us a good 30 years of trying to sort out ARDS to get the pendulum to swing back towards where we've really taken a different look at how we're using fluids and how we're using pressors. And we'll see that in a few slides later on down the line here. So the overall effect of shock was really thought to be a reduction of tissue perfusion. There was inadequate blood flow, inadequate oxygen delivery, so that we were unable to meet cellular metabolic requirements. And this is still one of the pillars of our understanding of shock. And it really is kind of a supply-sided phenomenon. So when we look at oxygen delivery here, plotted against oxygen utilization, and the green line demonstrates where most of us live from day to day, and that we can have alterations in oxygen delivery, but we still are meeting our oxygen utilization requirements. So even if our oxygen delivery drops a little bit, we're on the flat part of the curve, and there is no impairment of tissue perfusion. And this is what many people call a flow-independent status. Now, as the flow decreases and you get down to a critical DO2, this is where we can run into problems with oxygen utilization. And the curve drops off fairly quickly. And then this part of the curve is called the flow dependent status. So as oxygen delivery changes, oxygen utilization changes as well. And as oxygen utilization drops further and further, that results in worsening tissue perfusion and worsening shock. And so once again, a flow dependent oxygen delivery status. Now, in this area, it's difficult to predict from one patient to the next. So when have they deteriorated to a level where physiologic support is completely inadequate? And the goal of the fluid resuscitation is to get them back up on the flow independent part of the curve. Now, again, that's a supply-sided thing. We're looking strictly at oxygen delivery to the tissue, with the idea that as long as an adequate amount of oxygen is being delivered, then the mitochondrial electron transport chain can continue to function, and we can turn 3 carbon molecules into ATP and energy for cellular metabolism. But what's become clear in recent years with many types of shock, and especially shock associated with inflammatory states, is that those inflammatory mediators lead to an impairment of intracellular mitochondrial electron transport. And this is related to nitric oxide production. So that even if you're delivering an adequate amount of oxygen to the tissue, those cells cannot metabolize that oxygen to make ATP. So this explains why that there is a reduced oxygen extraction even when there is seemingly adequate oxygen delivery. So shock is a progressive process. Patients can typically compensate for shock up to a point, particularly young patients and or patients who don't have any significant chronic comorbidities. When they're compensated, there may be no significant physical findings. When they become uncompensated, that's when it's fairly obvious to even the casual observer that the patient's in shock. Small to modest amounts of shocks can still be catastrophic, particularly if it's allowed to progress over an extended period of time, of hours to days. But very severe shock can be recovered fairly quickly when it's recognized promptly and treated appropriately. So the different types of shock, and going back to Blaylock's initial descriptions, led to the earlier nomenclature of hematogenic or hypovolemic shock, septic, neurogenic, cardiogenic, with intrinsic being the primary pump failure, and extrinsic cardiogenic shock being an external force, such as cardiac tamponade or a tension pneumothorax, and then anaphylactic shock. The contemporary classification has shifted this around to group things together that have a similar physiology, and specifically the vasodilation associated with sepsis, neurogenic shock, and anaphylactic shock is grouped together to become distributive. The hypovolemic still remains hypovolemic. The intrinsic cardiogenic is cardiogenic, and then the extrinsic cardiogenic was renamed as obstructive shock. So we'll talk about hypovolemic shock first, and it's pretty straightforward. It's a volume loss. Typically, we think about it in response to blood loss, but it could also be the ongoing fluid losses for other reasons. And so that volume loss leads to hypovolemia and decreased cardiac output with some initial compensation. And the cardiovascular response happens both on the macrocirculatory and microcirculatory level. So one of the things that's happening is that the interstitial fluid shifts spaces. And so it's going both into the cells and into the vascular tree. So when we talk hypovolemic shock, it means the intravascular volume is decreased. And so your body essentially shifts fluid from the interstitial space into the vascular tree to try to compensate. And then on the microvascular level, what's happening is that you've got pre and post capillary sphincters across all tissue capillary beds. And these are constantly adjusting to try to maintain an adequate tissue pressure gradient across the tissue to maintain flow. Okay. And it's the stroke volume from the heart, the cardiac output, and the systemic vascular resistance of the vessels that regulate this pressure and flow. So as we look at the patient's blood pressure and cardiac output in early hypovolemic shock, they're able to compensate very well. So there's essentially no change in blood pressure or cardiac output. So there's really no external way of seeing that they're potentially in trouble. As they continue to lose additional volume, then their cardiac output and stroke volume decrease, and which causes a decrease in the pressure gradient across those capillaries and decreased capillary flow. And those pre and post capillary sphincters will continue to adjust their vasomotor tone to try to effect a useful pressure gradient across those tissues and maintain flow. And so this happens in a selective fashion. So it's not just happening across the entire body, but it'll happen in certain tissues first to divert flow away from skin, fat, and muscle, which can tolerate a prolonged period of low flow, to try to protect the more sensitive organs. Now, if volume loss continues and additional selective vasoconstriction needs to occur, then that's when the splanchnic bed in the kidneys will be affected next to preserve flow to the brain and the heart. There's a lot of mechanisms in place to both compensate for the additional volume for the initial volume loss, and then to preserve flow to key organs when there's continued volume loss. So going back to the view of the patient's blood pressure and cardiac output, as they lose more and more volume, they continue to compensate, but eventually the blood pressure will start to be affected, both with decreased pulse pressure and then eventually a decreased mean arterial pressure. And then if the cardiac output were to be measured in this state, you'd see a decline in cardiac output. Then you continue to lose volume, then you really lose that pressure gradient and the ability of the pre and post capillary sphincters to continue to compensate. Okay. And this is where we get into the uncompensated shock, where blood pressure and cardiac output really fall off the cliff. So this cycle of volume loss that leads to decreased cardiac output and decreased O2 delivery, which leads to decreased energy production, oxygen debt, and developing acidosis. And eventually that'll lead to impairment of cellular function, which ultimately will lead to decreased myocardial function and further decreased cardiac output. And this is a big part of that decompensated shock. So in addition to the microvascular changes, where the loss of the ability of the pre and post capillary sphincters to maintain a pressure gradient, the cardiac output plummets not only because of the decreased preload, but also decreased contractility. So the classes of hemorrhagic shock have been codified, and this is kind of standard trauma care, where we see in class 1 shock, when approximately 15% or up to 15% of the blood volume has been lost, that the body compensates pretty well, and there's little or no signs that they've lost that much blood. They progressed to class 2 shock, where 15 to 30% of the blood volume was gone. Now we start to see some changes. Again, the patient's body is able to compensate, but we start seeing some increased heart rate to maintain a cardiac output. But beyond that, not much difference. It's really when we get into class 3 shock, where 30 to 40% of the blood volume is gone, that we see more significant tachycardia, the blood pressure starting to drift down and decrease pulse pressure. And then finally, class 4 shock, which is greater than 40% of the blood volume is gone, and we see significant declines in heart rate, significant declines in blood pressure. The reason why trauma care is so focused on bringing a lot of resources to the patient immediately is because most trauma patients coming in will be maybe a little tachycardic and a little anxious because they've just been in a trauma. And it's impossible to tell, is this just a temporary effect of increased sympathetic tone because they were in a trauma, or is it they're in class 1 or class 2 shock, and if there's ongoing unrecognized bleeding, they'll be in class 3 and class 4 shock very quickly. And if you don't recognize it until it's class 4, then oftentimes it's too late. So basic trauma care is really geared towards identifying the situation when the patient's in class 1 or class 2 shock, when you have the ability to prevent any further deterioration. Now, moving on to septic shock. This one's quite a bit more complex because we have a lot of different things going on. With sepsis, or really any pro-inflammatory state, which would include pancreatitis, major injury, major surgery, and so on, that inflammatory cascade has a lot of crosstalk with the clotting cascade. And so when you get increased systemic inflammation, you get increased thrombosis and decreased fibrinolysis. And so eventually you'll get some clot formation in the capillaries, which is going to decrease microvascular flow, thus impairing tissue perfusion. In addition, we get a capillary leak, which leads to increased interstitial fluid, and that fluid's leaking out of the intravascular space that's causing hypovolemia. So you get an element of hypovolemic shock with sepsis. And then finally, the pro-inflammatory state leads to increased nitric oxide production, which leads to systemic vasodilation and impaired microvascular flow. There also is some direct oxidative injury due to the production of superoxides related to the nitric oxide production and the impaired mitochondrial dysfunction that was noted before. That leads to impaired cellular function, which will then lead to reduced organ function. So a little bit more about inflammation and vasodilation. It's in addition to nitric oxide, there's something else going on here. And one is that you get the activation of a potassium ATP channel. So what happens is this channel in the normal state is typically closed, and in the pro-inflammatory state, it gets stuck open. And so potassium leaks out of the cell that alters the transmembrane potential. And when the transmembrane potential changes, then these voltage-gated calcium channels close and intracellular calcium levels will decrease. Now, this is really important because calcium is necessary for vasoconstriction in a couple of different ways. One is your alpha adrenergic agents require calcium in a couple of steps to bind to calmodulin, which is one of the intracellular signals, and then calcium is needed for actin and myosin to constrict. So when you decrease intracellular calcium, the ability to vasoconstrict is impaired. And then on the nitric oxide side, you get an upregulation of a cell surface protein called inducible nitric oxide synthase. And what this molecule does is it's an enzyme that catalyzes the cleavage of the nitrogen off of an arginine molecule and uses that nitrogen to make nitric oxide. And nitric oxide then signals a cyclic GMP-mediated pathway that leads to vasodilation. So once again, in pro-inflammatory states, the decreased intracellular calcium impairs vasoconstriction, and the increased nitric oxide facilitates vasodilation. So, to say it again, septic shock has elements of hypovolemic, distributed, and cardiogenic shock. And that's one of the reasons why septic shock is so difficult to treat because it's very hard to determine how much of these could be occurring, because it could be just one of these elements or it could be any combination or all three. Now, just briefly on cardiogenic shock, we won't spend much time on this one, but typically we think of the pump failure and acute systolic heart failure. And so the primary treatment for that is afterload reduction, oftentimes augmented with diuresis, and occasionally inotropes are added to assist with myocardial contractility. Now, diastolic heart failure can be a little bit more challenging, but the primary treatment for that is blood pressure control and heart rate control, and then address the intravascular volume, because sometimes diastolic heart failure can respond to fluid boluses. Then with obstructive shock, again, it's primarily cardiac tamponade or tension pneumothorax. The key here is that it must be recognized early so that the underlying problem can be treated. No matter what you do with fluids and inotropes and whatnot, until you relieve the obstructive element, you're not going to be able to treat this effectively. So the primary thing to remember here is that it's almost always happening after an injury or an intervention. So whenever assessing somebody for shock, if they've had a recent penetrating injury or a recent invasive procedure, just to have obstructive shock on the radar. Now, I'm going to go back to hypovolemic and distributive shock, because these are the two that we have to try to sort out most frequently. And in the surgical intensive care unit, almost all of our patients are at risk for either one of these. Certainly any trauma or post-op patient we think of as being at risk for bleeding and hypovolemic shock. Also, it's not uncommon to have a lot of fluid shifts and fluid losses from drains, from GI output, that could lead to hypovolemic shock. In addition, all of these patients almost always have some significant inflammatory response. Again, whether it's infection, major injury, major surgery, any kind of significant tissue disruption, pancreatitis, and so forth. So they're all at risk for distributive shock as well. So trying to assess the difference between these two processes is a major part of basic ICU care. So I like to think about, well, what's happening to the capillaries? We've talked about it already, but to clarify, in hypovolemic shock, the capillaries are constricting to try to compensate. And in distributive shock, they're dilating. Again, in the pro-inflammatory state, we talked about the reasons for dilation there, again, nitric oxide and calcium homeostasis. And then in neurogenic shock, we have widespread vasodilation due to decreased sympathetic tone. This is something we may see in the surgical intensive care unit when in the trauma patient that has a spinal cord injury, or probably more commonly, the postoperative patient that has epidural analgesia, and our vasodilation and decreased sympathetic tone is iatrogenic. In anaphylaxis, that vasodilation is mediated by massive histamine release, but no matter what the cause, that vasodilation is the downstream problem that we have to deal with. So hypovolemic shock, constricted capillaries, should we give them fluids? Yes, that's the problem. They have inadequate intravascular volume, so the primary treatment is to replace that volume. Should we use pressors? Generally speaking, you want to minimize pressors. They're already constricted, so giving them a medication to constrict further is ultimately going to lead to even worsening tissue perfusion. And this was a big problem in the early days of using pressors, is that we didn't recognize what the true underlying physiology was. We just saw, oh, here's a medication that can make the blood pressure better. So we had patients in hypovolemic shock who were already vasoconstricted and then became uncompensated, so their blood pressure dropped. We gave them pressors, made the blood pressure better for a temporary period, but ultimately failed. And so for a long time in surgical education, there was really a bias against using pressors in any situation because of this. But as we'll see with distributive shock, pressors have their use. They're not the enemy. They're frequently exactly the right thing to do. And again, in distributive shock, when the vessels are dilated. So should we give fluid in distributive shock? And the answer is, yeah, it's reasonable to give some fluids. It can help buy you some time. With the massive vasodilation, you've increased overall capacitance and increased the potential intravascular volume space. So by giving them fluids and filling up the tank, you can improve the hemodynamics. And again, when we had the huge bias against using pressors, we oftentimes, pretty much all the time, treated distributive shock with just huge amounts of fluids. And we patted ourselves on the back that we made the hemodynamics better, but only later started to realize that all that extra fluid had a number of downstream effects that were not good. And so as we've reassessed our approach to shock, realizing that distributive shock was kind of an inappropriate vasodilation, then using pressors in that situation to reestablish an appropriate vascular tone is exactly the right thing to do. So once again, getting back to, well, if so many of our patients could have hypovolemic component and could have a distributive component, again, how do we tell the difference? Well, this is mainly by the history and the physical exam. Trying to figure out intravascular volume is a very difficult task, and there's no great way to assess intravascular volume. Things we look at, like tachycardia and urine output, might tell you something about intravascular volume, but they're pretty nonspecific. Filling pressures, the CVP, and the wedge pressure, or the pulmonary artery occlusion pressure, are difficult to interpret, and there's a lot of chronic and acute problems that alter ventricular compliance, which changes the pressure volume relationship with the heart. So those filling pressures are really hard to use as an indicator of end diastolic volume or preload. In fact, there's studies going back to the early 1980s that show that filling pressures really are not good indicators of preload. Now, the stroke volume variation may be a helpful adjunct, and this is looking at the change in stroke volume from beat to beat to beat expressed as a percentage. And this requires an arterial line and specialized equipment attached to that arterial transducer. And there's a number of different products out there. A growing body of literature to support their use, but as of yet, none of that is really relating the use of these devices to meaningful clinical outcomes. Decreased pulse pressure also may provide some insight. Again, the patient needs an arterial line, and this is really just looking at the pulse pressure on the waveform. And in addition, the way that waveform varies with respirations also might provide some clues about intravascular volume. The straight leg raise can be a helpful test, and this is when we are, again, with an arterial line in place, measuring the blood pressure, and then have the patient lie, very quickly, lay them supine, and then raise their legs up. And by raise them up, you really have to pick them up off the bed and up to a greater than a 45-degree angle. So you really have to pick up. So you've got to talk to the patient and the staff around you about what you're doing. Otherwise, they think you're crazy when all of a sudden you start pointing their feet towards the ceiling. But what this will potentially do is that rush of venous blood that's pooled in the lower extremities comes back to the heart. If you see an improvement in respiratory variation, pulse pressure, stroke volume, and blood pressure, then that usually is a helpful sign that the patient will respond to additional volume. So when you raise their legs up, oftentimes it takes 10 to 20 seconds to see an effect, and the effect typically only lasts for another 10 to 20 seconds. So you lift their legs up, you see that they respond or not, and then put their legs back down, sit them back up, and then write those fluid orders as appropriate. Ultrasound evaluation of the inferior vena cava is also a useful adjunct and is getting used more and more. It's certainly something in my practice that I've started to use routinely as an assessment of patients, even when I'm not worried about them being in shock, just to get a baseline. And then a fluid challenge may be appropriate. Now notice, every single one of these methods to assess intravascular volume, I've assigned really pretty vague terms to them that might be helpful, may be helpful, could be useful. Again, because none of them are on their own are great. Now, combinations of these, and in particularly looking at the trends, is very much a useful way to approach this. So even though, say, the heart rate and the CVP as a snapshot might not tell you much about the patient at this point in time, looking at how those parameters change over time can help you make better clinical decisions about intravascular volume. So here are just a couple of pictures of, on the top, looking at the IVC with bedside ultrasound, and typically we use the cardiac probe or the sector probe, and you could use potentially the curvilinear probe for this. And the image on the left is looking at in the cross-sectional view, and the image on the right is the same vessel with a probe turned 90 degrees to see it in the longitudinal view. And this view is typically just below the costal margin, typically a little bit to the right of the midline. You can also get a pretty decent look at the vena cava in many patients laterally when you're looking from the right side of the patient, usually mid to posterior axillary line, kind of the same place that you would put the ultrasound probe to do a fast exam. If you increase the depth and point the probe in the correct direction, you can find the IVC from the side as well and get that same longitudinal view. And then the image below is looking at an arterial waveform tracing, and the red tracing in the middle, and the green tracing on the bottom is the ventilator triggering, and you can see that the waveform varies with respiration. So again, when you see arterial waveform variation like that with respiration, and particularly if that variation is greater than 10 millimeters of mercury, that oftentimes can suggest the patient will respond to a volume challenge. All right, now getting back to difference between the hypovolemia versus distributive. So if we're thinking about hypovolemia, does the history suggest it? You know, have they had blood loss? Do they have excessive fluid losses of any kind? GI losses, excessive urine output, sweat, usually coupled with inadequate fluid intake, whether it's PO intake or our IV fluid orders. Then does the physical exam support hypovolemia? And thinking about it, what's the body doing to compensate? It's constricting capillaries, so that'll lead to diminished skin turgor, cool, clammy extremities, and delayed capillary refill. Now, contrast this with the vasodilatory state or distributive shock. Again, the history, do they have a source of inflammation that fits? And are there any other systemic signs that there's a big inflammatory response? And on physical exam, because they're vasodilated, typically you'll have warm extremities and normal capillary refill. The difference between these two in the old days, a lot of people called warm shock versus cold shock. Warm shock being the vasodilatory state and cold shock being the vasoconstricted state. So when you first begin assessing the patient and you're thinking, is it hypovolemic versus distributive? And of course, always when appropriate, thinking about cardiogenic and obstructive shock if needed. But you get it down to hypovolemic versus distributive, it's generally reasonable to just start with some fluids while you continue to have your ongoing reassessment and collect more data. Then when you made the decision that, yep, looks like hypovolemia, continue with the fluids and minimize the pressors. And if you've turned your attention towards distributive shock, then it's go with the fluids, but have a greater reliance to start and escalate your pressors. And again, those pressors are designed to reestablish some appropriate vascular tone. Now, if you do go down the cardiogenic pathway, then typically minimizing fluids and try to avoid pressors, because again, afterload reduction is the primary treatment here, so we typically avoid pressors. However, if it is right heart failure or diastolic failure, those may respond to fluids, and it's going to be a difficult assessment in many cases. So if it's obstructive shock, fluids may buy you a little bit of time, but again, dealing with the underlying problem is of paramount importance. Now, a question that comes up a lot when we're talking about this fluid resuscitation is, well, what if the patient has a history of chronic congestive heart failure and they have a decreased ejection fraction, or they have renal failure, and particularly a dialysis patient? And so there's a big hesitance to give these patients a lot of fluids because you don't want to worsen their CHF or get them fluid overloaded because of their renal failure. But if the patient is hypovolemic, those patients need that fluid just as badly, if not more so, than a patient who had an okay heart and okay kidneys. So if you're certain that they're hypovolemic, then your approach to resuscitation is unchanged. If you're on that fence of, boy, I think they're hypovolemic, but I'm still really not sure, and you want to be cautious, then that's where you might start with smaller boluses, but that bolus is in very quickly, and it's just immediate reassessment. And it's just bolus, reassess. In fact, really any situation, that's kind of what it is bolus and reassess. It's one of the reasons why a lot of people don't like critical care, because it's tedious. It's doing the same thing over and over again and constantly reassessing and then changing gears as soon as you have enough data to tell you that maybe you picked the wrong path or the clinical situation has changed and you need to change your thinking. Now, the fluid to use, I won't spend a lot of time on this because it's been established for a long time now that with colloid versus isotonic crystalloid, that there's no difference in outcomes, just colloid is a lot more expensive. The prices change quite a bit, and the last time I checked a couple of months ago in my system, a 25 grams of albumin was about 6 times more expensive than a liter of crystalloid, and a unit of blood is about 100 times more expensive. So, never use blood products solely as a resuscitation fluid for intravascular volume. You use it if they're bleeding. Colloid, generally avoid. There's some data that suggests that albumin in sepsis may be beneficial, but it's not very convincing. And there's also data in neurocritical care, particularly head-injured patients, that you probably should avoid colloid in those situations because it may worsen intracranial hypertension. Now, we're going to use crystalloid. Which one to use? Normal saline versus Ringer's lactate are the two basic choices. There's another balanced crystalloid similar to Ringer's lactate called Plasma-Lyte A, but it's a lot more expensive, and there's data showing there's no improvement in outcomes, so we generally kind of ignore that one. But saline versus Ringer's, and for many, many years, the thought was dealer's choice. It doesn't really matter which one you use. Either one's fine. They both increase the intravascular volume, but by approximately the same amount. And depending on where you trained, people had different ideas of which one really was preferable. We're heading more towards using Ringer's lactate as the primary crystalloid of choice. And this is based on a large study published in 2018 from Nashville, and they looked at over 15,000 patients in 5 ICUs, and they got either normal saline or a balanced crystalloid, again, either Ringer's or Plasma-Lyte A. And what their results showed that the balanced crystalloid group had decreased mortality and decreased need for renal replacement therapy and decreased persistent renal dysfunction. So based largely on this study, most intensivists now are leaning more towards use of Ringer's lactate rather than normal saline as their routine choice. Now, certainly, if the patient is hyponatremic, the higher sodium content of normal saline might lead you towards its use. And in the neurocritical care world, they tend to run towards keeping serum sodiums higher. And so the higher sodium content as well as the slightly increased osmolarity of normal saline may be beneficial in helping control intracranial pressures. All right. So a little bit more on some guidelines on fluid resuscitation, and this is from the Eastern Association for the Surgery of Trauma. They caution us against getting too crazy with the fluids. Start the fluid resuscitation aggressively, but reassess and start backing off as soon as you can. They reinforce the idea that the filling pressures are not great tools to guide your resuscitation. Other lesser invasive dynamic modalities such as the continuous cardiac output monitors that give you the stroke volume variation may be helpful, but it's really unclear. Just blindly administering a fluid challenge, although oftentimes it's reasonable to do so, should be done with caution, and shouldn't do it blindly. You should be doing it with some purpose-driven thought process in mind, not just reflexively doing it without thought. And then the guidelines for early goal-directed therapy in sepsis call for frequent fluid assessments, but they don't really tell you how to do it. So it's kind of left up to the practitioner to figure out how do you want to address your methods to assess and reassess the patient. They comment on focused ultrasound use and arterial pressure waveform analysis, and they say a conditionally recommend, which basically says if you use it and you have figured out ways to interpret this information in a constructive fashion, then go ahead and keep using it. But they can't just make a blanket statement saying that these technologies are actually helpful. And it's not superior to just standard protocols of a clinician who's paying attention to the patient and reassessing them. So it's a lot on getting the fluid started. And we're really good at figuring out when to start the fluid resuscitation, but we're not so great at figuring out when to turn the spigot off and slow down the fluid resuscitation. For a long time, it was really down to evidence of oxygen debt. And this was from 1993, but for a good two and a half decades, this was considered really the basis of endpoints of resuscitation, is that you've got to use data to show that you've eliminated the oxygen debt, stopped anaerobic metabolism, and reversed the tissue acidosis. And these are still used to a significant extent. So lactate is the one that probably gets used the most these days, and both the initial lactate as well as the follow-up lactates to assess tissue perfusion have been used for at least 35 years as a helpful adjunct to that reassessment of the patient who's undergoing a fluid resuscitation. And particularly in the trauma world, there's a lot of data in the 80s and 90s showing that if you can get the lactate to turn around quickly, the patient's going to do better. Base deficit was also used a lot, and there was a lot of back and forth in the trauma literature for many years over which was better, lactate or base deficit. But both of them have a fair amount of data showing their utility as a prognostic indicator in assessing the adequacy of resuscitation. And then mixed venous oxygen saturation also has its proponents. And all of these, in trauma, hemorrhagic shock, in sepsis, have been used in many different venues as an endpoint of resuscitation, showing that these parameters are normalizing to help decide when's it time to slow down the fluid resuscitation. And this graph from an article in Critical Care Medicine in 2004, they compared looking at the anion gap, just basic metabolic acidosis, to the lactate, to the base excess, to the strong ion gap, and really all of them were potentially useful in predicting survivors versus non-survivors as an endpoint of resuscitation. Other things that have been used, looking at heart rate variability, and I won't spend a lot of time on this, but there's a growing body of literature looking at both acute and chronic problems that relate heart rate variability to all sorts of different physiologic processes. So that's something that, potentially in the future we'll see more about that with ICU care. Other things that are growing in popularity are near infrared spectroscopy, to basically look at local tissue beds to see how well they're perfusing. Other things like sublingual capnometry, gastric tonometry, microdialysis catheters, and transcutaneous catheters have all been used, and periodically grow in popularity and then wane again, because it's cool technology, but we haven't figured out which, if any of these, can we truly pair up with meaningful clinical endpoints. So, like I said, we're pretty good at knowing when to begin the fluid resuscitation, and again, Ringer's lactate typically being the preferred fluid. When to slow down the fluid administration is less clear, but certainly the clearance of lactate and the metabolic acidosis are important tools in assessing these patients. But just a frequent physical exam is the most important thing to do. We have all the technology in the world, but it's the person at the bedside that really makes the difference. All right, now moving on to pressors and inotropes. We're looking at the adrenergic agents, and certainly dobutamine, primarily a beta agent, dopamine, alpha, beta, and dopamine effects, epinephrine, alpha and beta, norepinephrine, mostly alpha with a little bit of beta, and phenylephrine, it's pretty much pure alpha with very little beta effect. So those alpha adrenergic agents, bind to the alpha adrenergic receptor, which sets off a complex cascade of intracellular signals with calmodulin as that intermediary. The vasopressin receptor, which vasopressin binds to, blocks that cyclic GMP-mediated nitric oxide pathway and prevents vasodilation. Angiotensin II is getting some increased attention these days, with some recent studies showing its potential utility in vasodilatory shock, and its primary mechanism is it increases intracellular calcium. And then my favorite cation, calcium, as mentioned before, it's necessary for the intracellular alpha adrenergic signaling, and it binds to the troponin in the actin filaments that allows the actin-myosin cross-bridging that leads to smooth muscle contraction. All right, now the inotropes, the beta adrenergic ones we mentioned, dopamine, epinephrine, dobutamine, and norepinephrine to some effect, and the phosphodiesterase inhibitors, amrinone and milrinone, which cause increased contractility and then typically vasodilation. And then through the same mechanisms mentioned on the previous slide, calcium is also a positive inotrope. So you've got all these choices, and which ones do you use? And there's no great data on this. Most of what's out there is either small studies or just kind of general consensus. And so the surviving sepsis guidelines recommend Levophed as the initial choice. There are some fairly robust studies in sepsis looking at Levophed versus dopamine, and no difference in outcomes, but just decreased arrhythmias with norepinephrine. So that tends to be the choice. So again, the sepsis guidelines say Levophed's your first choice. Epinephrine or dopamine are okay options, but again, increased incidence of arrhythmias. And with epinephrine infusion, you also tend to get some insulin resistance that can be very difficult to compensate for. Phenylephrine, with its pure alpha properties, you don't see those arrhythmias, but you tend to see some tachyphylaxis with that. So as that phenylephrine has been infusing for longer periods of time, you end up needing to use larger and larger doses to achieve the same effect. There are many institutions that use phenylephrine as their primary, and again, very little data to support one alpha agent versus another. My personal bias is to use Levophed, and then as I'm increasing the Levophed, get to a point where you feel like you're at enough Levophed and it's time to add a second agent. And intensivists are all over the map on where's their threshold for adding a second agent. When I'm adding a second agent, I tend not to use another alpha agent. If I'm adding epinephrine or just going up on the norepinephrine, to me, I'm hitting the same receptors. So I probably will get a similar response. So for me, the second agent is vasopressin, a different mechanism of action. Most places tend to use vasopressin as just a straight dose, 0.01 to 0.04 units per minute, and tend not to titrate this based on the blood pressure. And to me, that makes sense because vasopressin is misnamed. It's not really a pressor. It doesn't cause vasoconstriction. It prevents vasodilation. And there's animal studies in sepsis and in hemorrhagic shock that show that endogenous vasopressin levels initially increase in the stressed metabolic state until your posterior pituitary runs out of vasopressin, and then those endogenous vasopressin levels plummet. So when we're using it, oftentimes it's with the idea of, I'm just trying to replace what the body ran out of. And so this is really hormone replacement therapy. Now, when I'm adding the vasopressin, thinking about it as hormone replacement therapy, I'll also be looking for any evidence of adrenal dysfunction and the other hormone replacement therapy that might be needed in this situation. Now, the angiotensin II role is unclear. The studies show that the use of angiotensin II can decrease your norepinephrine use, but the studies have not shown any linkage to improvement in outcomes, so the jury's still out on this one. I tend to be more aggressive with using calcium. I figure if angiotensin II increases intracellular calcium, I can achieve the same thing a lot cheaper by just giving calcium IV. Again, no data on that. That's just my personal preference. All right, now if we're using pressors or inotropes, do we feel obligated to place a central line at this point? And traditional practice says, yes, we should be placing central venous access whenever we're using pressors. But there has been a growing acceptance of administering pressors via peripheral access, and some small studies, but we're seeing more and more comfort with using pressors through a peripheral IV. And where I will do this is typically when I think that the pressor need will probably be either a relatively low dose and or for a relatively short period of time. How short is short? I don't know. It's kind of make it up as we go along, but typically we'll start it with peripheral, and then at some point, and I'm either escalating doses or it becomes obvious that it's not going to turn around very quickly, then get that central line in. Now, as far as which inotrope to use, even less to say about this. Typically, it's dobutamine versus milrinone, but you could also consider dopamine or epinephrine, and this is really up to the practitioner. For me, it's if I also happen to be bradycardic, then it makes it pretty easy to choose dopamine or epinephrine over the others. So I'll just leave it at that. Again, very little data suggesting one of these is better than another. All right, now we'll talk about sepsis. So we talked about septic shock a little bit. Here we'll go into a little bit more detail on some key elements of the surviving sepsis guidelines. So we'll start with the traditional definition of sepsis, which is systemic inflammatory response syndrome plus infection. And that's the normal state. If you have an infection, you should have an elevated heart rate, elevated white count, elevated temperature. So the traditional definition of sepsis is really a normal physiologic response. So when we say, man, that patient's septic, we mean the sick patient. We mean the patient that's in trouble. We mean severe sepsis or septic shock. SIRS plus infection plus organ dysfunction, and septic shock, taking it to the further extreme of impaired organ perfusion despite adequate fluid resuscitation. But there are some problems with this definition, and this was a large chart review looking at patients who had sepsis, over 100,000 of them in a 14-year period, and over 12% of them did not have a systemic inflammatory response. So already, 1 out of 8 septic patients don't fit the definition. Okay. So the third international conference to look at consensus definitions for sepsis published their recommendations in 2016 to say, boy, we really need to rethink this definition of sepsis, severe sepsis and septic shock. We know SIRS are not very sensitive and really nonspecific, that inflammation is a normal part of the body's response to infection. And so what differentiates sepsis from just normal response is that you get an impaired host response that ultimately leads to organ dysfunction. Okay? That organ dysfunction may be occult, and that's why it's important to look for signs of impending organ dysfunction, and that's where looking at the lactate becomes ever more important. That unrecognized infection may be the cause of a new onset organ dysfunction. So in the typical approach to sepsis from the traditional perspective was you start with the infection and you look for the organ dysfunction. But we know now, sometimes it's the organ dysfunction that comes first, and that should be the trigger to look for the underlying infection. In addition, the organ dysfunction itself may not be due to sepsis. So specific infections might lead to local organ dysfunction that's not due to a dysregulated host response, but it's directly due to some other factor. And a couple of examples of this would be if the patient has a bad pneumonia and a huge infiltrate, and they have respiratory failure due to the infiltrate, not due to sepsis, or the patient who has an obstructing kidney stone leading to pyelonephritis, and that kidney stone obstructing the ureter is leading to the renal failure, not sepsis. So if you have any patient with you think is septic, then you really have to look closely for any organ dysfunction. If there's anybody who has some new organ dysfunction that you can't explain, you got to look for infection. All right, so to revisit the traditional definition, sepsis, SIRS plus infection. As we've noted, a lot of these patients don't have SIRS. The new organ dysfunction, well, a lot of them don't have any obvious organ dysfunction. It's subtle, it's occult. And then the new organ dysfunction might be occurring in the absence of sepsis. So they say now that this is the proposed definition, that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection, and that this organ dysfunction can be identified as an acute change in the SOFA score. Okay. So again, this is a proposed definition. There's a lot of people who have concerns about this, and that clause of it's life-threatening organ dysfunction caused by a dysregulated host response. Well, what's dysregulated host response? How do we don't have a test for that. We can't measure that. So although I feel that this is a more accurate statement, it still doesn't help us identify patients any more effectively. So I think we're going to see this evolve more in the coming years. And then septic shock is just that subset of sepsis that leads to shock. And again, we just talked about that. All right, so the organ dysfunction that you're looking for, well, it can manifest in any number of ways, and here's a partial list of some of the more common ways we see it. Probably most commonly, it's the respiratory dysfunction, renal, and neurologic, but any of these things can occur in any order and any combination. There's some studies showing that in the hospitalized patient who becomes septic while they're in the hospital, that the metabolic encephalopathy is typically the first organ dysfunction to present. And this is really tough because patients become encephalopathic in the hospital for any number of reasons. And that's why we have such a difficult time of identifying and effectively treating sepsis in the patient who's already in the hospital for some other reason. Now, we mentioned that SOFA score, and this is one of a large number of organ failure assessment methodologies. And it's taking your PA2 to FiO2 ratio, serum creatinine, serum bilirubin, blood pressure, platelet count, and the Glasgow Coma scale, and then assigning a score to it. And more numbers is worse. The SOFA score has been shown to be associated with worsening mortality. And so here's 3 different ways of looking at it. The initial SOFA score, the higher it is, mortality goes up. The highest SOFA score in a 24-hour period, same trend. And the mean SOFA score at that 24-hour period, same trend. So this is, again, one of many organ failure assessment scores that many ICUs use some method like this to help assess patients. Where it is of limited utility is that by the time you get that SOFA score, you've already got lots of organs failing. So it's kind of questionable about, like, how much does it really help a practitioner who's paying attention? Is calculating the score really changing your approach to the patient? But in any case, the more organs failing, the worse off the patient is, which certainly is intuitive. And the general rule of thumb, which still seems to be true, is that for every additional organ system failing increases the mortality by about 20%. Now, the QSOFA is saying, boy, we may not have a bilirubin on a patient, we might not have an art line on a patient, we may not be getting an ABG yet. Is there a shortened way of kind of getting at the same idea of, can we identify a patient in trouble? And so it's just looking at respiratory rate greater than 22, greater than or equal to 22, Glasgow Coma score less than or equal to 13, and systolic blood pressure less than or equal to 20. And again, more points is the worse off you are. So there is a growing movement towards using that QSOFA score in non-ICU patients to help identify who's in trouble and might need more attention and a higher level of care. And then for the patient that's in the intensive care unit, and we're monitoring a lot more things, the logistic organ dysfunction system is another one of these organ failure assessments that some people are using. Again, this is from that same group that has the proposed change to the definition of sepsis that a lot of people question, and a lot of people are questioning the utility of these organ failure assessments and how and should they be used. So I think we'll see more of these, but I think we'll also see a lot of differing opinions on how and when they should be used. So really what it comes down to is we've got these methods and many others, but ultimately it comes down to people looking at the patient. In addition to what we see here, I think we'll also see a lot more development of artificial intelligence systems to leverage the electronic health record to look at much larger data sets and trends of patient parameters that will help us identify not just for sepsis, but for any patient that is at risk for significant and sudden deterioration. So now, the Surviving Sepsis Guidelines, something that's been developed in the last 16, 17 years, and it started with the beginnings of the Surviving Sepsis campaign that grew out of the Barcelona Declaration, which was at a conference in Barcelona, Spain, where representatives from these three societies talked about sepsis care and how can we improve it. Because at the time, sepsis mortality was like 30 to 40%. And they looked at acute coronary syndrome and STEMIs and said, boy, 20, 30, 40 years ago, the mortality of STEMIs, somebody survived their STEMI to make it to the emergency department, their mortality was 30 to 40%. But advancements in ACLS and in STEMI care to include use of beta blockers, use of antiplatelet agents, TPA, and percutaneous interventions, we've dropped that mortality to under 10%, really under 5% in most institutions now. So they said, how did the cardiologists do it? How did they drop that mortality from 40% to 5%? Let's try to do the same thing with sepsis. And so they said, we'll get the experts together and come up with some guidelines. And so the first set of the guidelines came out in 2004 with the intent that about every 4 to 5 years, we would update those guidelines. And it's broken down into 5 basic categories: screening and identification of patients to find out who has sepsis, the initial fluid resuscitation, the treatment of the underlying infection, the ongoing hemodynamic support after the resuscitation is underway, and then adjunctive therapy and supportive care. We'll just talk about the adjunctive supportive very briefly, because this is not unique to sepsis. This is just all basic ICU care that we do for pretty much any of our patients. So we'll spend some more time on sepsis screening and the initial resuscitation and source control. But just very briefly, some of the changes in the Surviving Sepsis Guidelines over the years are they've solidified their stance on norepinephrine as a recommendation for the first choice vasopressor. They've gotten a little bit more detailed regarding antimicrobial strategies. They removed activated protein C, or Zigris, from the initial recommendations. They've changed the approach to assessing adrenal dysfunction and steroid use. They've shifted the blood sugar goal for glycemic control a little bit, and they've commented specifically on immunoglobulins and IV selenium to say, boy, really, we don't need to routinely use those. They had been mentioned in earlier versions of the guidelines because of some initial positive studies, but follow-up studies did not pan out. So, going to sepsis screening and how do we find these patients? So, there's no diagnostic test for sepsis. You know, procalcitonin may help us identify if an inflammatory response is due to an infection or not, but it's not a test for sepsis. Lactate is not a test for sepsis. An elevated lactate typically means there's some problem that you need to be figuring out and paying attention to, but does not equal sepsis. Basically, it really just boils down to if there's a new infection, look for some organ dysfunction, and if there's new or worsening organ dysfunction, then look for an infection. And it's really a clinical diagnosis. Okay. Now, the initial resuscitation, and we talked about it in the shock portion of this lecture, but some more specifics to sepsis is, and this is straight out of the guidelines, we recommend that in the resuscitation from sepsis-induced hypoperfusion, at least 30 milliliters per kilogram of intravenous isotonic crystalloid fluid be given within the first 3 hours. And then following that initial fluid resuscitation, additional fluids may be needed based on your reassessment of the patient's hemodynamic status. Now, the 30 mil per kilo number has gotten a lot of attention because there's really no data supporting that particular choice of a fluid volume. This is really based on looking at a number of different studies and getting expert consensus. That it appears that does seem to be the magic number, that you really need to start with that. This causes a lot of heartburn with clinicians, whether it's the patient that I think is septic, but I'm not positive that it is, and I don't want to hit them with a ton of fluid unless I'm really sure. There's the patients that have a bad ventricle, and I want to be a little bit more cautious of how I'm comporting my fluid resuscitation. And then there's the patient that, hey, I gave them 10 per kilo and they got better. Why do I need to be obligated to give them 30 per kilo if I can demonstrate improvement with a lesser bolus? But again, this is based on looking at a lot of different studies and coming up with a consensus. And it's born out of the understanding that we hurt a lot more patients by under-resuscitating than we do by over-resuscitating. And so the consensus group figured, you know what, if a couple of people need to be intubated because we have a little bit too much fluid, that's a lot easier. It's a lot easier to deal with some isolated respiratory failure you do to volume overload than with under-resuscitation and global hypoperfusion. All right, they recommend crystalloids as the fluids of choice, but suggest that, hey, you might want to consider albumin if you're having to give a whole bunch of crystalloid. Again, no real specific guidelines on exactly when do you switch to albumin and how much albumin. It's up to the clinician to decide. Right. And then how to assess the adequacy of resuscitation. Again, what are the endpoints of resuscitation? And this was a study in 2001 that really crystallized our approach towards a aggressive fluid resuscitation in sepsis, and really helped us understand that sepsis is a time-dependent problem. So a single U.S. center, 263 patients, and the usual therapy was whatever the clinician felt was needed for fluids. And they targeted a mean arterial pressure of 65 and a CVP of 8 to 12. A urine output of greater than 0.5 milliliters per kilogram per hour, and compared that with the intervention group, the early goal-directed therapy group, where they included a mixed venous oxygen saturation. And then they targeted the mixed venous oxygen saturation. So they gave fluids to achieve the parameters of the CVP. If the patient still had a MAP under 65, then pressors were added for both groups. And then if the mixed venous oxygen saturation was low, then either inotropes or blood transfusion, both to increase oxygen delivery, were added in the intervention group. And what they were able to show was a decrease in mortality from 46.5% mortality down to 30.5%. So a huge improvement. And so based on this study, a lot of us started using mixed venous oxygen saturations as a routine part of our ICU monitoring of septic patients and in non-septic patients that were in really bad shape too. So follow-up studies looked at lactate clearance versus that mixed venous oxygen saturation, and showed that, hey, no difference in mortalities. You could use either or. So it opened up the possibilities of how to monitor these patients, but still using a biochemical parameter to assess occult hypoperfusion. Okay? So one of the criticisms of early goal-directed therapy is that it is a pretty small study. Another criticism was that using central venous pressures was of questionable utility. And then a third question came down to the idea of the decision to use blood transfusion versus inotropes, and particularly the blood transfusion component of that those patients got a lot of blood. And so three large studies sort of revisited the idea of early goal-directed therapy. So in this one from 2014, the PROCESS trial compared early goal-directed therapy versus their homegrown protocol, in which they used kind of heart rate and blood pressure ratio to assess a response to resuscitation, versus, quote, usual care, unquote, where the clinician could give the fluids in whatever fashion and reassess the patient in whatever fashion they felt was appropriate. And they showed no mortality among the three groups, no mortality differences among the three groups. Right around the same time, a very similar study in Australia and New Zealand with 1,600 patients looked at early goal-directed therapy versus usual care. Same answer, no difference in mortality. And then soon after that, another study, this time from England, with over 1,200 patients enrolled, very similar study design, also showed no difference in mortality. So a lot of people interpreted this as early goal-directed therapy is no good. But that's not really true. Early goal-directed therapy works. The difference here is the usual therapy has just gotten much better in the dozen years after early goal-directed therapy. Early goal-directed therapy informed the basic usual care of these clinicians. So by the time these patients got randomized to these studies, they'd already received typically about 2 liters of fluid already before they even got randomized. Okay. So these studies don't say early goal-directed therapy doesn't work. They say it's not the only thing that works. And what's pretty interesting about this to me is that in all three of the studies, usual care, meaning an experienced clinician got to just assess the patient and make the decisions on their own, was just as good as the protocolized methods. So I got away from, and most of us stopped using early goal-directed therapy because of the increased cost of looking at mixed venous oxygen saturations and transfusing more liberally. Said, hey, if we can do this by following a lactate and using our clinical judgment, that's a lot simpler and cheaper than early goal-directed therapy. So, and it's also based largely on these studies, this idea of the 30 per kilo bolus. So this kind of, puts together a couple of different components of this. But basically, it's that fluid resuscitation. If their lactate's up and or they're hypotensive, then they still need 30 per kilo. So notice, even if they have end-stage renal disease and on hemodialysis, or they have CHF, that 30 per kilo recommendation still stands. Okay? Again, you're just probably going to reassess the patient a little bit differently, but the basic approach is still the same. And then the other considerations to assess adequacy of resuscitation and tissue perfusion is a whole host of things like blood pressure, heart rate, urine output, using bedside ultrasound, CVP. So just what we mentioned before, that there's all sorts of things that you can use to help make better decisions, that you can't rely on any one of them, and it's the trends that make the difference. Getting back to the surviving sepsis guidelines, there is a specific comment on using a mean arterial pressure of 65 as the general target for your pressor management. And this was out of some thought that maybe supranormal blood pressures might be beneficial in reestablishing adequate tissue perfusion. But there was a study, and the graph shown on the left, that the targeted a map of 85 versus a map of 65. But as you see in the curve on the right, there was no differences in mortalities. So that's why the guidelines chose to address this directly, to say, yep, shooting for a higher map strictly for the management of tissue perfusion and sepsis is really not necessary. A map of 65 is adequate. They suggest guiding resuscitation to normalize the lactate for those who started with an elevated lactate level, and that the use of a central venous pressure alone to guide fluid resuscitation cannot be justified. A little bit more about lactate, and there's a lot of data going back to the 1960s in trauma, in sepsis, that lactate is an important tool to have in the intensivist toolbox. So this one, again, on the right, going back to 1964, showed elevated lactate associated with worsening survival. And then the comment on the left, 50 years later, measuring lactate can help risk stratify patients to help drive our prompt, aggressive early treatment. Some other studies to help support this, that lactate is more important than blood pressure as a prognostic parameter to look at. Okay. And especially that initial serum lactate and mortality as an independent predictor, separate from overt organ dysfunction. And then the study from 2010 on the right there that shows that assessing the lactate during the first 8 hours with the idea that you're trying to reduce that lactate by at least 20% every couple of hours is associated with improved meaningful clinical outcomes. And then here is yet some more data more recently showing that this is looking at lactate and mean arterial pressure, and it shows that lactate is the strongest predictor of mortality, again, better than the mean arterial pressure, using that lactate level to guide the resuscitation. All right, now going on with the surviving sepsis guidelines, a little bit of what do they have to say about source control. And basically, obtain routine microbiologic cultures, including blood, before starting antibiotics, okay, as long as there's no substantial delay. So getting those antibiotics in quickly. The general consensus is get it within an hour. Again, there's a lot of discussion back and forth over what is the right amount of time, but certainly avoiding any delays in getting antibiotics in. As far as which cultures to get, probably blood cultures are the more important one, because that will, if the blood cultures are positive, that will frequently alter your duration of therapy. Cultures of any other fluids or any other tissue samples is really going to be dependent on the clinical situation. Recommend that those antimicrobials be started within an hour in both sepsis and septic shock, and then it needs to be broad spectrum. So again, depending on the clinical situation and local antibiograms, that will determine what do you think the appropriate broad spectrum therapy ought to be. As far as source control, then again, very much dependent on the clinical situation and that individual patient on what do you need to do to assess the patient and achieve source control. But generally speaking, as soon as you get the patient stable enough, then if there is tissue that needs to be cut out or an abscess that needs to be drained, then getting it done as promptly as possible. So putting it all together, they came up with these 3 and 6 hour bundles, to help drive the idea that this is all time dependent. And that's the 3 hour bundle is once you've identified that you think the patient's septic, measure that lactate level, draw the blood cultures, get the antibiotics in, and get your 30 per kilo bolus and get all of that done within the first 3 hours, which is very doable. It's not hard to do, but it requires a lot of attention. And then the reassessment within 6 hours, reassess the patient if they're still hypotensive. And it's not wait until 6 hours, it's at any point within that 6-hour bundle. Reassess them, add vasopressors if needed, and we figure out what other parameters might you need to measure, like venous pressures or mixed venous oxygen saturations, or use your bedside ultrasound or whatever else you might be doing, and then remeasure that lactate. To really hone in on the time sensitivity of all this, there's a growing group of emergency medicine and intensive care docs who are saying, think about it as a 1 hour and 3 hour bundle. You don't want to be waiting until the end of 6 hours to say, okay, I guess I better check my lactate now. It's really as soon as that initial fluid bolus is done. So you can get that initial lactate, blood cultures drawn, first dose of antibiotics in, and your 30 per kilo in within the first hour. And then go immediately to your 6 hour bundle things right then. So again, it's not evidence-based, it's more just general consensus, and the idea that anything we can do to help shorten the times up is probably going to be helpful. So those 3 and 6 hour bundles have translated over to the Centers for Medicare and Medicaid Services and their core measures for sepsis care. And you say, boy, we need LIP, so licensed independent practitioner, documentation of severe sepsis. So somebody writing in the chart, I think this is sepsis. Or somewhere in the chart, you've got documentation of a new infection, 2 or more SIRS, and some new organ dysfunction. And so those 3 things might be in totally different parts of the chart, but if they're happening concurrently, then that equals sepsis. And then for septic shock, kind of the same thing, LIP documentation, or you've got a lactate greater than 4 and persistent hypotension after a 30 per kilo bolus. And then before 3 hours, so this exactly mirrors the 3 and 6 hour bundles from the guidelines. Before 3 hours, initial lactate measured, blood cultures drawn, broad spectrum antibiotics given. And if you're using combo therapy, more than one antibiotic, that second antibiotic has to be started before the 3 hours is up. And then repeat that lactate measurement if the initial was greater than 2. Right? And then the core measures for septic shock, again, 30 per kilo bolus within that first 3 hours. The blood culture is the antibiotics, same things there. And then the 6 hours that you've repeated the lactate, you've added a pressor if needed, and you've documented a reassessment of the perfusion status. That reassessment of the perfusion status consists of either of the following: a focused exam to include those elements shown below, and or any 2 of the following: a central venous pressure measurement, central venous oxygen measurement, bedside cardiovascular ultrasound documentation, or the performance of a passive leg raise or a fluid challenge. So either of those, and I just do both. I'll do the focused exam plus whatever I've done from the right-hand column. All right, so the challenges is screening for infection. In the emergency department, it's pretty straightforward. The screening is happening for the infection and for the organ dysfunction immediately. So the time, the clock has started, and if there's anything leading us down the sepsis pathway, we're kind of already looking for these things. It's the patient that's in the hospital for some other reason that becomes septic that it becomes much more difficult to sort out that kind of ongoing monitoring in whatever fashion it's happening. How often are the vitals being measured, what labs are being ordered and when, and so on and so forth. It's very hard to sort out in the inpatient. But looking specifically, some of the common things that are being measured but oftentimes neglected is if their blood sugars are creeping up, or their insulin requirement is increasing, if their platelets are starting to drift down. They've got that altered mental status that is a non-specific thing, but oftentimes a key indicator. If the CO2 on a metabolic panel is decreasing. And then maybe these scoring tools like SOFA and QSOFA could be helpful. And then, as mentioned before, the early electronic warning systems, again, the algorithms that are harnessing the electronic medical record to help alert us to any changes. And then when we see some evidence of a new infection and or new organ dysfunction, thinking about the lactate or a mixed venous oxygen saturation to look for any occult signs of hypoperfusion. So once you're there, then it initiates that prompt response. As mentioned before, culture's drawn, antibiotics immediately in the fluid resuscitation, and then start talking about source control. You know, there's been a lot of pushback, particularly on the lactates, and I'll hear this from practitioners all the time, like, why are you getting all these lactates on my patients? And I use the analogy of chest pain. I say, well, if I have a patient in the hospital who has chest pain, and we know that it's probably not acute coronary syndrome, but we get an EKG and maybe a troponin just to make sure, nobody really blinks at that. Because we say, oh yeah, boy, if we don't want to miss one. And so we know we're going to get a lot of false positives. It's the same with sepsis. We're going to get patients who have some altered mental status, who have a new white count, who have any number of things happening that makes us think it might be sepsis. So we check that lactate and do some other things. And if the lactate's normal and the further assessment is, boy, it doesn't look like sepsis, great, then we move on. We know there's going to be a lot of false positives, and we just know we have to remain vigilant because we're better off assessing the patient and reacting early, and then de-escalating quickly once we realize it's not sepsis. So we're better off doing that than waiting and hesitating and not treating sepsis in a timely fashion. So it's all about reassessment. Frequently physically reassess the patient, recheck the lactate, consider whatever invasive monitoring you think may be helpful, including bedside ultrasound. Another challenge is figure out when time zero is. As I mentioned in the ED, it's easy to say when time zero is for the most part. But in the hospitalized patient, it's hard to say when did we really decide that, yep, I think it might be sepsis. And then we can begin our 3 and 6 hour bundles from there. A lot of the recommendations are for the LIP to just write it in a note, say, here's the time that I decided I think it's sepsis, and then the clock begins then. And then on the reassessment, if we decided, boy, it looks like it really wasn't sepsis, then again, writing in a note saying, yep, we thought it was sepsis, but we've ruled it out now and sepsis is not present. The other big challenge is in handoffs. The patient's going from the ED to the floor to the ICU, or the floor to the ICU, or the OR to the floor, and so on and so forth. It's those handoffs. So somebody started the ordering of cultures and antibiotics and fluids. Who's picking up the patient on the other end that's going to ensure that those got completed and the patient got reassessed? That's one of the big challenges. And then just the general change in culture. We know that just publishing guidelines has limited effect. That of the guidelines that are out there, we only practice them effectively about half the time. And then it takes a good decade or two for evidence to be translated into practice. I remain hopeful that with sepsis, that we're now 15 years after the initial sepsis guidelines, that we're getting ever closer to really translating this into widespread effective practice. But the reality is that change is difficult, and then oftentimes it's not that we re-educated ourselves and that we got everybody to start rowing in the same direction, as it is that it's just as the older generation transitions out and a newer generation that's just used to the new way of doing things, that unfortunately that's how change oftentimes is affected. All right, so what seems to work for sepsis? That it's a hospital-wide performance improvement program, that we treat it like the things, other things that have big resources behind them, like stroke or MI or trauma, that we have standardized order sets to help guide effective and consistent treatment, that we use progress note templates to help prompt the providers to document effectively, that we create reliable handoff processes, that we develop the appropriate pharmacy and lab supports to make it easier to do these things in a timely fashion, and that we look at our own data. We do our case reviews and we use our data to go back and figure out how can we do it better. And this all has to come it's both a top-down and a grassroots approach. We got to have clear guidance from leadership, but you also have to have those boots on the ground teams that are driving it. All right, so once again, the key to sepsis is if you suspect a new infection, then look for some new organ dysfunction. And if you detect new organ dysfunction, then look for new infection. That is really the key to identifying these patients promptly. Right. And again, sepsis is a time-sensitive problem necessitating early recognition, prompt administration of antibiotics, immediate fluid resuscitation, and frequent reassessment. It's just like those other time-sensitive problems. All right, now, lastly, some basic ventilator management. And so we're talking about respiratory failure. It's some problem with either the airway, the alveoli, and the blood supply, or the blood supply to the alveoli, the chest wall, the diaphragm, the nervous system to include the neuromuscular junction, or the pulmonary circulation. And then we break down the types of respiratory failure into hypoxemic, hypercapnic, perioperative, or associated with shock. And it can be a combination of those things. So type 1 respiratory failure, some of the more common things that we see: ARDS, atelectasis, cardiogenic pulmonary edema, pneumonia, pulmonary embolism, pulmonary fibrosis, and so on and so forth. A little bit more about ARDS is it's the acute diffuse inflammatory lung injury that is notable for increased vascular permeability, so ongoing capillary leak leading to pulmonary edema that then results in bilateral radiographic opacities. And ultimately, it leads to increased physiologic dead space and decreased lung compliance, all leading to hypoxemic respiratory failure. The definition of ARDS has evolved over the years, and in 2012, the joint session that put together some guidelines on this, they call it the Berlin criteria, and they replaced the term acute lung injury and got rid of it and just said acute lung injury is mild ARDS. They clarified the acute component to it, saying that the onset is within 7 days of some other defined event like pneumonia or sepsis or any other infectious process injury or surgery or whatever. That reinforced the bilateral opacities seen on a chest X-ray or CAT scan. One thing they removed, though, was a requirement to exclude heart failure. The old definition of ARDS stated that we needed to exclude exclude heart failure, but the recognition that you could have heart failure and ARDS exists. So they said you don't have to exclude heart failure. The only time you really need to look for it is if you don't have some other explanation for your bilateral lung opacities. And they broke it down into mild, moderate, and severe, and using the PO2-FiO2 ratio to distinguish between the three. And there you see the increasing mortality as the severity worsens. Now, type 2 respiratory failure, which is hypercapnic, oftentimes this is the obstructive problems, asthma or COPD, or things like central hypoventilation or obesity hypoventilation syndrome, and then the things that cause impaired work of breathing, like impaired abdominal or chest wall mechanics, or the neuromuscular disorders. Type 3 is that postoperative respiratory failure, and often it's suboptimal analgesia leading to impaired ventilation, obesity, ascites, airway secretions, and preoperative smoking. And again, this results in either type 1 or type 2 or both, along with the type 3. And then type 4, it's the patient's in shock, so as part of your resuscitation, you're intubating the patient to gain airway control and the anticipated worsening oxygenation and or ventilation. But your basic mechanical ventilation goals are some combination of the following: correcting the hypoxemia, compensating for acidosis, meeting increased demands, potentially improving cardiac function, assisting neural and or muscle dysfunction, and in rare cases as an adjunct to the short-term treatment of acutely elevated intracranial pressures. Permissive hypercapnia is a concept that's kind of grown in understanding and acceptance over the years, and it's saying there are certain situations where we're willing to accept a decreased minute ventilation. We don't have to make the minute ventilation and the PCO2 normal in everybody. These patients aren't normal, so making their numbers normal isn't necessarily a helpful thing to do. Where we could use permissive hypercapnia is anytime we want to avoid hyperinflation or excessive ventilating pressures, so to minimize auto PEEP and to decrease risk of ventilator-associated lung injury. We typically do not use permissive hypercapnia in patients with significant intracranial processes and increased intracranial pressure. Now, the modes of ventilation, we'll talk a little bit about it here, but honestly, it probably doesn't matter, or at least we don't know which mode is the best. No matter what mode we're using kind of the same targets. The 6 milliliters per kilogram ideal body weight is a reasonable starting point for most patients, regardless of what mode you're using. Now, you might take into account chronic problems that could lead to a smaller than normal tidal volume, so the restrictive lung diseases, or chronic problems that could lead to a larger than normal tidal volume, which is the obstructive diseases. But regardless, you pick your target tidal volume, then whatever mode you're using, that target tidal volume remains the same. Similarly, decisions about PEEP and FiO2 are independent of what mode you're using. So you make those decisions, you decide what mode you're going to use, and if it's a pressure-based mode, then you're just setting the amount of pressure the ventilator is delivering, and then looking to see what the volume you get is, and then adjusting from there. If you're using the volume cycle, then you're setting that tidal volume and looking to see how much pressure it's taking, and adjusting from there. But either way, the target tidal volume is the same. Pressure control ventilation, or PCV, and volume cycle ventilation, VCV, either one of those could be used in assist control or SIMV. Then the next one down, PRVC, or pressure regulated volume control, and then CPAP, or the spontaneous modes. And so looking at these side-by-side comparisons, in volume cycled ventilation and PRVC, we set the patient's tidal volume. In pressure control and CPAP, it's variable. For the driving pressure, or the delta P, then in pressure control and CPAP plus pressure support, we would set that. But in volume cycled ventilation and PRVC, that driving pressure is going to be variable. The I time, or the inspiratory time, again, for pressure control and for PRVC, we set it. And in volume cycled and CPAP, it's variable. And then the flow is variable for pressure control, PRVC, and CPAP, but we dial in a flow for volume cycled ventilation. So those are the differences between these modes. You say the target tidal volume remains the same, the PEEP remains the same, the FiO2 remains the same, just how those breaths are delivered is slightly different. And so from one patient to the next, the patient may find one mode more comfortable than the other. And that's primarily what drives our thought of which one to use, is we're still targeting the same tidal volumes. We're looking at the same peak pressures and trying to minimize those pressures, and just pick the one that seems to be the most comfortable for the patient. Now, the modes where the patient controls their own flow tend to be more comfortable, which is why we've grown to use more pressure-based modes. The idea of PRVC was it's a pressure-based mode, but it still gives you that guaranteed tidal volume, so it maintains a more consistent minute ventilation. Now, back in the 60s, 70s, and getting to the 1980s, the technology was different, and it was very hard for ventilators to deliver pressure-based modes effectively, and so it tended to be uncomfortable, and so patients required a lot of sedation. So in the old days, we tend to use volume cycled ventilation as the primary mode because of that, but the technology is better, and these other modes tend to be more comfortable. Now, having said that, if I get a patient that is not synchronizing well with the ventilator, and I cycle through these different modes to see which one works best for them, if volume cycled is the one that seems to be the most comfortable and can deliver the tidal volume with the least amount of pressure, then I'll go with that one. But most of the time, it tends to be one of the pressure-based modes. So whatever mode you pick, when you want to increase oxygenation, then there's a few basic things you can do. One is to increase the mean airway pressure, and the other is to increase the FiO2. Increasing the FiO2 doesn't fix the underlying problem, it just helps improve oxygen delivery. Increasing the airway pressure, we hope, is helping to fix the underlying problem. So the way to do that is either increase the PEEP, or increase the peak airway pressure, or alter the I to E ratio, or any combination of those. We typically will think about the PEEP and the I to E ratio. We tend not to increase the peak airway pressure for this application because we want to minimize airway pressures, overall airway pressures, to try to reduce the incidence of ventilator-associated lung injury. Alter ventilation, then it's changing the minute ventilation, change the respiratory rate, or change the tidal volume. Potentially could also use the I to E ratio to affect this. It's important to note that if you're particularly in PRVC and pressure control ventilation, where our I time is set, that as you change the rate, the I to E ratio will change with it. So if you're going up on the respiratory rate to try to blow off the CO2, but your I to E ratio is changing, so your expiratory time actually drops, you may actually worsen minute ventilation by doing that. So you just have to be careful about how you're doing it, think about that I to E ratio, and then just look at the minute ventilation after you've made the change. Other basic things to think about with ventilator management is just good oral care, and typically that's nurse or RT driven. Early mobilization, get the patient sitting up in bed and get them out of bed. Intubation is not an indication for bed rest. And getting them out of bed and moving will help decrease their time on the ventilator and decrease their delirium. And decreased delirium is associated with decreased mortality. Need at least daily assessment of the adequacy of their securement devices, so what's holding in the ET tube. Is it working? Is it providing you adequate placement and security? And look for potential pressure injuries secondary to the contact points of these devices. Additional ongoing ventilator management is just continue to modify the ventilator settings to achieve patient vent synchrony, and try to make the patient try to make the ventilator breathe like the patient, not the other way around. So if you start with making the patient breathe like the ventilator, that means you're sedating them more. And try to avoid that. Try to see what you can do to tweak the ventilator. As I mentioned before, just changing the modes to see if a different mode is more comfortable for that patient. Changing the trigger, whether it's a pressure-based trigger or a flow-based trigger, to see what's working better for that patient. Altering the PEEP and the tidal volume is going to try to figure out what else can you do to get the ventilator to try to do what the patient wants. And then when that doesn't work, then you're forced to go up on the sedation and make the patient breathe like the vent. And then key is the frequent assessment of ongoing need for mechanical ventilation. Use sedation protocols, target that sedation towards a very specific goal, things like the RASS score, the Ramsey, things like that. So there's something for the nurses to titrate their sedation towards. Minimize the sedation as much as possible. Patients don't have to be knocked out just because they're on the vent. Some patients do. Many patients are pretty comfortable with little or no sedation. Think about using your opioids to deal with any subjective dyspnea. And then other non-pharmacologic treatment of pain and anxiety. And then at least once a day, lighten the sedation, unless there's some overwhelming need to keep them sedated. Lighten that sedation frequently to see how they do. And then you couple that with spontaneous breathing trials. We're really not that good at figuring out when patients are ready to extubate. But if we just turn the ventilator down and let them breathe on their own periodically, they'll tell us when they're ready.